Tonight we're going to talk power and magic in prostate cancer management. And so just before we get started, just a quick acknowledgement of country of the turbulent Yagara people, where I'm coming to you from today, and just acknowledging the elders past, present and emerging. Physio for nearly 10 years and Menshealth for 9 years, and my current role is with Ramsay Health, where I work through the Ramsay Health Plus clinics, which is kind of like a outpatient style clinic. Across 3 clinics at the moment, so Southport Private's the closest for you guys, Greenslopes, Northwest and St Andrews, where I was today. I have had a couple of chats with the urologist at John Flynn, and they are quite keen to have me come down there as well. So I might be looking to do probably in the next, hopefully, month or two, hopefully starting to do a clinic down there, probably about probably at least one morning a fortnight to start off with anyway, so which is handy. Also run a website which is Menshealth.physio for some education type stuff. Last year I finished this graduate certificate in exercise medicine oncology, which is kind of what today's mostly kind of aimed at, and also involved in a pelvic floor clinical trial at the University of Queensland, which will be wrapping up towards the end of the year. And I was saying just before, the surfboat photos are because last week I gave this talk at Karawa Surf Club, where the Gold Coast group meets, and I'm also a member of Karawa, so I had to include this cracking photo from a couple of years ago. They were quite lucky that someone took of us who was just down at the beach one day. So the primary reason why I kind of do what I do and why I enjoy what I do and trying to improve more and more is this study kind of really hit it home a couple of years ago. So this is 2019. It was a 10-year follow-up study by the Cancer Council Queensland. And basically it showed, we know that more and more men are living longer and longer with prostate cancer after being diagnosed, but we know that quite a few aren't living well. So still got a number of men who are incontinent months to years after treatment, lots of men with erectile dysfunction, lots of men with body composition changes, and a range of other issues. And so I'd like to start changing this so that 10-year time, and the next one's done in 2029, that hopefully we're making ground up and more men are doing far better after being diagnosed. We'll probably just whip through. I was going to make an assumption, but I probably should ask you two guys. Have you guys both been diagnosed and been through treatment?
We've both been diagnosed. I haven't got a treatment plan yet.
Okay.
I just had my PET scan last week or 2 weeks ago. So.
Yeah. Okay. Cool.
But I guess in summary, most of these two guys here will probably end up having radiation treatment at some point.
Yeah.
Neville here is taking ADT.
Yeah.
As well as having some radiation shortly, and Malcolm's still getting these PET scan results.
Yeah, cool. Okay, cool. So I'll rip through this next part because this is kind of more the pre-diagnosis part, but I'll point out a couple of things. So the quick facts, we know it's now more than about 24,000 diagnosed a year, so about 1 in 5 men will be diagnosed. Prostate cancer's got one of the highest survival rates if caught early, so that graph down the bottom right there, so stages 1, 2 and 3, really high survival rate at 5 years. Stages 4 and beyond, not quite as good. And this other graph shows that since the late 80s, the 5 and 10 year survival rate continues to climb and climb and climb. So really good odds of surviving through prostate cancer. But yes, we want to make sure that men are doing well and doing better than they have been. And one of the fastest growing group is the active surveillance group. So in years gone by, practically probably 99% of men that would come into the clinic had been, had a biopsy, been diagnosed, and were going in for surgery. And it's all quite a bit of a shock and everything else. And now I see more and more men who might have been diagnosed from anywhere from kind of 2 to 7 years ago and have been kind of watch and wait. And then PSA is climbing and another biopsy shows that it's starting to accelerate, and then they go on to have surgery or other treatment. Prostate gland sits below the bladder, and basically its sole job is to produce fluid to protect and enrich the sperm. The three main diseases: prostatitis, benign prostate hyperplasia, and prostate cancer. And signs and symptoms of prostate disease are some of those. And the important thing that we always tell people is that there's actually really no signs and symptoms of prostate cancer. It's the signs and symptoms of prostate disease. So those symptoms are a sign that something's wrong with the prostate, and it may be cancer, but it also may not be. And then the testing, as you guys have been through, so typically PSA, urologist, digital rectal exam, and then MRI potentially, and then biopsy, and then the PET scan as well. So that's just a quick whip through there in case there was anyone who was not quite, it was more pre-diagnosis. So we'll touch on the male pelvic floor and training, because that's still what a fair chunk of my week looks like. So in terms of post-prostatectomy, so surgery, we know about 90% will experience some urinary incontinence, and around about 5% may still be incontinent after 12 months. More and more these days are either mostly continent or very close within 3 to 6 months, and the pre-op training is good. Incontinence, in terms of the radiation, it can still be a side effect, but it's typically not initially. It tends to kind of creep in further on down the track. There can be a bit of fecal kind of urgency and frequency while going through the session, going through the radiation treatment, and that often reduces. And there's a couple of subtle differences between pelvic floor training for the two, so surgery or radiation. I don't expect you to read this, but this is basically some of the many proposed reasons as to why men leak after prostate surgery. The basis is that we don't quite have the exact answer, and it's probably a combination of a number of different things for different men. So it can be changes in tissue around the surgical site, can be changes in the bladder neck, can be a whole range of different stuff. The pelvic floor, so top right is our traditional kind of model of the pelvic floor, which is kind of pelvic floor as a sling, and it just holds the bladder and the other pelvic organs up. Over the last decade or so, there's been a lot more detailed study into the male pelvic floor, and we have this bit more detailed model. So we've got our pubic bone at the front, just above the penis, tailbone at the back, bladder in here, and the prostate shaded in the back there. So in terms of previously, for men who are going to have prostate surgery, we'd tell them to squeeze through their bum muscle, which pushes everything up and across that way. We know that that's not as effective for men going through surgery, and instead we try and activate this small extra bit of sphincter muscle, and also this muscle in the base of the penis. Because this bladder smooth muscle in here is what gets mostly disrupted during surgery. In terms of radiation, we also encourage men to kind of do activate through the bum muscle, just because there can be the issues with a bit of fecal urgency and everything else. So keeping everything tight through there is also important. So in terms of radiation, we typically encourage still activating around the front, which we'll get to in a second, but then also activating through the back to kind of keep both the front and the back of the pelvic floor nice and strong. Should have, yeah, it's coming up in a second. This is kind of the scans we take in the clinic and in the research project. So to get these images, we place the ultrasound probe just behind the scrotum, so pointing back up. And this is what it looks like before surgery. So we can see where the bladder comes into the urethra and then coming down and out towards the penis.
Your attention, please, ladies and gentlemen.
We've got this bulb in here.
So keep it up. $50 cash is member Muriel Byers. That's membership 17806. If you're present, please make your way to reception to claim your prize. If our winner is not present tonight, our daily cash flash will jackpot to $100 tomorrow evening. Thank you.
Sorry about that.
Congratulations to Muriel, hey? And then we've got the rectal angle out through here. Post-surgery, the biggest change, one of the biggest changes, the prostate would be kind of hidden in here. And when it comes out, the bladder drops down lower. So there's a bit of a loss in terms of anatomy internally. And so everything can come downwards. In terms of what that looks like, in terms of in action. So this is my pelvic floor, which I recorded in the lab up at New Q. So this ultrasound machine that we've got up there is worth a lot more money than what we can get in the clinic. And so what we're looking at here is that's my pubic bone there. So it doesn't really move. Bit of my prostate there, and then where my urethra and bladder meets around about here. So a bit of bladder there. And then the urethra is coming down through here and out towards the penis. And so that's the bulb of the penis, one of our pelvic floor muscles. And that's our striated urethral sphincter or external sphincter, which is the main thing we try and activate in terms of trying to reduce the incontinence. And then we can also see my puborectalis or bum muscle is shipping in as well and pushing the bladder up as well. So it's typically a combination of all three muscles that we're trying to coordinate. In terms of surgery, we want most of the movement down here. In terms of radiation, we want a combination of here and here. But typically, I try and get men to train them separately. So focusing on the front and then focusing on the back, not necessarily combining all three at once, just to kind of get a bit of separation. Any questions while that's playing?
Is it beneficial to do these exercises before you start radiation?
Yeah, I think like most things, it's best to start beforehand, while there's kind of changes to sensation and everything else. So look, for most things, starting 4 to 6 weeks out is always beneficial, but there's never a time where it's too late to do it. So, yeah. In terms of activating the pelvic floor, so to activate through the front around that urethra, it's kind of 3 words we don't want to hear, and that's kind of shorten the penis. So if you're thinking base of the penis, trying to keep the tummy muscles nice and relaxed, and we're trying to just gently draw the penis through towards the tummy. For a lot of men that works. For other men, we'll change and talk about walking into cold water and lifting the nuts up towards the scrotum. So just as that wave's about to whack you, you're trying to bring the nuts up towards the tummy. In terms of activating through the back half of the pelvic floor, that's where we talk about trying to stop a fart. So you're trying to draw a fart back in, and that's how we activate the posterior part or the back of the pelvic floor. And we want to start slowly and softly. It's a bit more of a finesse to get it started, and then you can add some power later on. And then, yeah, if surgery, we want to focus on the front. Pelvic floor exercises, like most things, so they need to be progressive. So we normally start lying down and then move into sitting, standing, and then functional movements. So how you start your pelvic floor muscles and training shouldn't be how it ends. Should be kind of doing more and more challenging things. And so essentially, as men have surgery, or if they start to get a bit of a leak, months to years down the track from radiation, it's kind of identifying what things are causing you to have a leak and then trying to activate the pelvic floor before doing it. What does the evidence say? So in terms of radiation, there's kind of less evidence around it. Most of the pelvic floor stuff does tend to focus more on surgery. The initial studies weren't necessarily overly amazing, but the main problem was that they were teaching pelvic floor muscles how we teach them to women, without understanding that the anatomy is different. And so previously for surgery, a lot of the evidence was around squeezing the bum, which wasn't as effective. So there's been some more recent studies currently which are kind of showing better promise when we activate through the front, which is definitely helpful and helping. This kind of thing, again, don't expect you to read and explain and understand it all, but this little graph on the left is basically things on this side favors doing pelvic floor muscle training. So there is a reasonable effect, and there's only one that kind of showed an actual detriment, but the range was massive. So don't worry too much about that. And then the other one here is just saying like the different factors of pelvic floor training that make it more successful. And the main things in this one that showed that it was most successful was focusing on the urethra, so focusing around the front, starting it before surgery, and then using some kind of biofeedback device, so like an ultrasound, so you can see what you're doing. And then so this was just one of the recent studies from WA with Joe Milios. So pelvic floor intervention was basically starting about 5 weeks pre-op, pretty sure. And so at 6 weeks, 32% who were in the training group were dry versus 11%. And by 12 weeks, 74% of the ones that did the training intervention was 74% were dry, and 43% who didn't or 40% who didn't do it were dry. So the difference of about 30% between the two groups. Quick note on erectile dysfunction, because there's always doesn't always get talked to well, but it is quite common in the community, and do get a number of younger men, 30s and 40s, coming to the clinic looking for some advice. Does tend to increase 10% every decade. Post-surgery, it always affects just about all men, even with some nerve sparing. So doctor in Brisbane talks about like trying to get a plum out of the spider web. So to peel back the spider web to get the plum out, you're always going to damage part of the nerves. And so recovery can take quite a while. There's a study just a couple of years ago showed only 25% of men got back to their baseline function after 2 years, which is pretty low. And this is definitely an area that we can do better at. And one of the issues being that most evenings, most men will have anywhere between 3 to 5 erections during their sleep cycle, and that kind of stops. In terms of radiation, again, it's typically not a initial issue, but again, it can creep in over time due to a bit of damage from the radiation. Quick little note, cardiovascular disease still kills more men than everything else, essentially. And one thing we do want to take notice of, particularly of young, healthy men, is if they do have erectile dysfunction, or even if they're not healthy, in their earlier ages, our penile arteries are very similar to our cardiac or heart arteries, but much smaller. So if we're getting blockages in the penile arteries early age, it can be an indicator that the overall cardiovascular system's not doing so well. What do we do with it? Believe it or not, the gold standard for most things around erectile dysfunction is actually exercise. Most doctors and patients will kind of go towards the classic Viagra or the newer Cialis, but exercise is really important in terms of maintaining and keeping erections for all those effects on the right. So it increases the blood pumping through the system, increases our testosterone, muscle mass. We get more vasodilation. So if the blood vessels in the penis don't open up, there's not enough blood coming in, we don't get an erection. Failing that or combined with that, there's also tablets, injections, and then moving on to vacuum pumps and even surgery for erectile dysfunction. All right. So this part's definitely very key for you guys, but physical activity and exercise are often used interchangeably, but they're actually two different things. So physical activity is the much bigger, more broader term, and its simple definition is any movement produced by the muscles and requires energy. So getting up off a chair, physical activity, et cetera, et cetera. Whereas exercise is a subset of physical activity that's planned, structured, and has an objective of improving and maintaining one area of physical fitness. And there's a number of areas of physical fitness which we'll go through. So physical activity is typically a lower effect on our heart rate. Things like walking from the car park into the bowls club, gardening, golf is physical activity, especially if you're using a buggy and not walking the course. And a lot of work will also be physical activity. So we often get men in, they're tradies or they're working in mines or on power lines or all kinds of stuff. And they're like, well, my work is my exercise. Or farmers, they're a classic as well. And while they are physically active, which is good, they don't often enter the intensity level where all the good stuff is, which we'll come to in a second. So exercise typically will have an increase in our heart rate and breathing. And classic examples, running, lifting weights, rowing. But there is other things. So, for example, chopping firewood done in a short burst and fairly intense, that can count as exercise because the intensity level is higher. Yeah. So exercise pretty much always equals physical activity, but physical activity doesn't always count as exercise. And so they get commonly put together, but they are different things. And so when we talk around cancer, we really want to get to the nitty-gritty of exercise. Physical activity is great, but exercise is even better. So some of those components of fitness, which no one in the world is completely balanced in all of them, but aerobic or cardiovascular fitness, so the runners, the cyclists, for example, muscular strength and endurance, flexibility, balance, agility, power, speed are kind of our main components of fitness. So you can have someone that's really fit and strong with zero flexibility or poor balance. So yeah, even our greatest athletes you can think of aren't perfectly balanced across all of those. And then in terms of getting a bit more specific, we talk about our principles of fitness. And so specificity is a big one. So we need the exercise to be specific to the target that we're aiming for. So classic example here is, so if we're on ADT, which is, hormone replacement therapy, one of the side effects of that is can be losing bone density at about 5% a year. So, or up to 5% a year. So it can be quite a significant effect on the bones. Someone might really, really enjoy swimming and they might swim huge amount of hours every week. And that's really good for their heart health and some of their muscle health, but it's not doing anything for their bones because they're not actually loading the bones. So for someone like that, we wouldn't want them to necessarily stop all their swimming, but we also need them to find time to either go and lift some weights or pound the pavement and really get some load through their bones. So that's the specificity component. Reversibility is simply the old, if you don't use it, you lose it component. So I often joke with people that it'd be great if fitness was a bit like super funds. You put some in when you're younger and you reap the benefits when you get older. But unfortunately, doesn't matter at what age, if we stop doing something, our body does just revert back to its basic level to survive. Progressive overload is basically saying that whatever exercise program you start with or running program or anything, it shouldn't really look the same in 3 to 6 months time. So you should be able to lift more weight or do more reps, and you kind of need to, otherwise the body will just plateau and not won't kind of reap as many benefits. And then the fit kind of principle just talks about frequency, intensity, type, and time. And we'll talk about that in a second. So believe it or not, but our current exercise guidelines are the exact same for people with and without cancer. And so that's 150 minutes of moderate cardiovascular exercise, and we'll talk about moderate in a second, and about 2 strength training sessions a week. So they can be body weight, don't always have to join the gym, but they do have to be at a reasonable intensity, which we'll discuss as well. The intensity part's important, so bit hot, bit sweaty, bit short of breath, and the heart rate increases. That's kind of what moderate talks about. And we want to try and be as specific to the individual as we can. So in terms of intensity, we use this thing called the RPE, or rating of perceived exertion. So some people hate it because it reminds them of the 0 to 10 pain scale, which is obviously subjective. And so what one person's 10 out of 10 pain is different to another person's. And similar here, 10 out of 10 max effort is going to be different for each person on this call. So very light is pretty much sitting down watching TV. Light activity is something you can maintain for hours. So a very low level walk, for example. 4 to 6 out of 10 is moderate activity. So you're starting to breathe a bit heavy. You can hold a bit of a short conversation. So you're not recording, you're not giving out huge paragraphs, but you can still talk. And then vigorous is where we start to get a bit more uncomfortable, shorter breath, only kind of short sentences. And so most of the research continues to show that for most things related to cancer and exercise, we want to be around this moderate level. So 4 to 6 is where we probably want to spend most of our time, but getting into 7 or 8 for short pockets has additional benefits. So 2 or 3 is great, fantastic. 4 to 6, really, really good. Couple of short pockets of time, 15 minutes where we're up around a 7 or 8. Beautiful, perfect. 9 and 10 if you really like flogging yourself. But 9 and 10, well, unfortunately, depending on how you go through the radiation, if the fatigue starts to hit, a lot of things that you normally would say are 3 can feel like a 9. So it can start to become a bit of a challenge.
Can I ask a question?
Yeah, go for it.
Just in relation to like someone that might have coronary artery disease or hypertension or some other comorbidity, that would you still work out the same sort of perceived exertion levels, or would you have to adjust it?
Yeah, we kind of do still use that level. So depending on how unstable everything is, we might also use a bit of a heart rate monitor or something else just to kind of keep a closer eye on it. But yeah, sticking between a 4 to 6 is pretty safe for someone with other comorbidities. Going up into a 7, 8, 9, 10, a little bit more, is it worth the risk? Depends how otherwise fit they are as well and what medications, but 4 to 6 is typically still safe because it's a 4 to 6 for them. So it might be we might look at it and go, that's a pretty low activity. It might just be a slow walk on a bit more of an incline on a treadmill. But that for that person, it can definitely feel like a 4 to 6. So that's okay. Yeah.
Can I ask that?
Yeah, go for it.
I do about 5, 35-minute, 40-minute walks, and I'm 70.
Yeah.
Would you say that was adequate?
So it just cut out a bit, but I think Neville, you said you're doing about 35 to 40-minute walks, and you're almost 70.
Yeah, and I'm doing about 20 minutes on a rowing machine.
Yeah.
A day.
Perfect.
Is that enough?
Yep. Do you feel like you're working around that 4 to 6 when you do it?
Yeah, all right.
Yeah. So if you're feeling around that you're working around there, then great. If the walk feels a bit, the rowing machine probably feels harder than the walk, depending on how many hills you find. So
fairly low intensity, but
yeah.
I was
So
a
they're
professional long time and I move my limbs, so I still play.
Yeah.
I do 2 or 3 hour sessions of moving all my limbs and put it with a smartwatch. I get up to 130 in my heart rate.
Yeah, good. Yeah. No, that sounds great. So keep
So I
it
do
up.
that once. I do that once a week as well.
Sorry, I missed that last bit. Sorry, Devil.
So he does his drumming once a week.
Oh,
which
yeah.
is fairly vigorous.
Yeah, good. They're all these things definitely help. So, yeah, I don't think you need to change too much there.
I'm not bad. A few others. I'm not as good as him, mate.
In terms of weights, we use something quite similar. And so you can see on the left there's like an RPE. So an RPE of 10 is that you've got no reps left. So we use this idea of repetitions in reserve, which essentially is that. So you get someone to lift a certain weight and say you've prescribed them to do 10 repetitions. And when they get to the 10th one, we ask them, how many more do you think you could do? And if they think that they could do, 2 to 3 more reps, then they're working at about a 6 to 8. If they think they could do 3 to 4, then they're working at about a 4 to 6 moderate RPE. So it's a bit similar to the walking or the aerobic RPE, but instead of how hard you're working, we kind of can ask them how many more do they think they could do. So we kind of talk about it in the gym sense, like, have 2 to 3 left in the tank. We don't want them going to absolute fatigue every single time. We just want to have a couple of repetitions left in the tank, and that's how we do it in terms of strength training.
Yeah, thanks.
In terms of exercise oncology, and I've got a little bit of timeline in a second, but what we're talking about is using exercise to specifically target issues that arise during cancer treatment. So typically it's physios and exercise physiologists that have done a bit more training into it. There's some very, very safe and good community PTs, personal trainers, but there's some that probably don't quite have the training and understanding. But I can say the same thing with some physios or exercise physiologists as well. So it's just making sure that you're confident with what the person's doing and it feels right. And so we're wanting to target potential issues with specific interventions. So in terms of, 2 examples there, prostate surgery. We know that there's going to be issues with the urinary sphincter and some incontinence. So we want to really focus on pelvic floor training as well as other things. ADT, like we talked about before, loss of muscle mass and bone density. So we really want to focus on that strength training. So trying to lift some weights a couple of times a week, particularly to get load through the bones, is really, really important. So you can still do the things you enjoy, but really trying to get an extra strength session in here or there is the idea.
Can I ask a question, Tom?
Yeah.
It would appear that a lot of patients have ADT prior to having other treatment like radiation. We have ADT for about 6 months, and then they stop that and they would just then carry on with radiation treatment.
Yeah.
Do you know whether the loss of muscle mass and bone density would be a long-term effect with ADT? But do you know whether you see that immediately, or would it be something that would be only if you're on ADT long-term?
Yeah, so even 1 or 2 courses of ADT can still have, depending on the medication, but a number of them will be kind of like a 3 monthly dose, and then so it can take 3 months to wash out, and then a month or so after that, after it's supposed to stop working. You tend to see men will kind of notice the more the other physical side effects, so potentially changes in mood, the hot flushes, potentially tenderness around the nipples, like those. They'll notice those things, the loss in libido, etc. because you can see them and feel them a bit more suddenly. But the muscle mass loss, the fat mass gain, and particularly the bone density loss, you don't see it initially, and it's more of a slow burn in the background. So even 6 months of ADT can still have a significant effect. It's not just the ones that are on it for a year or two. Yeah. I always try and encourage men, if they haven't done one, and particularly if they've got a family history of like osteoporosis in the family, so low bone density, I try and encourage them where possible to see their GP and do a bone density scan, like before they start ADT or as soon as they can, because we particularly want to find the ones that have already got low bone density. So there's a bit of a increase in men who have got low bone density for a number of reasons. A lot of them might work long hours in an office, so in winter they don't see much sun, so they're not getting enough vitamin D. They might not be very active, so there's a reason, or they might have genetic factors that already put them at low bone density. And then if they go on hormone treatment, it's just going to magnify the problem even worse. So trying to specifically find those ones and get them exercising is definitely important. What does it look like in terms of like an assessment? Would normally be understanding like the cancer and what's going on and what the person likes doing, and then past medical history. So everyone's always got a bit of knee arthritis or an old foot injury here or there that we have to work through. We normally do a quick aerobic test, like a 6-minute walk test, and then look at some strength. So we might look at squats or push-up tests or grip strength, bit of balance testing. And then once we kind of have a baseline, that's where we kind of start from. And we can do this sometimes in groups, sometimes individual based. Depends on kind of the person's training level. If they're already engaged in activities, then great, we want to keep them there. If they're, never really exercised in their life, then we try and keep a closer eye on them while they're getting started. The role of exercise in prostate cancer. So just a quick little timeline of where we've gone. So probably through most of the 1800s, 1900s, it was all about kind of bed rest. So you've got cancer, really sorry, you stay in bed, you don't lift a finger, you don't get yourself a cup of tea, you rest up during treatment, you really don't do anything. Like you just absolutely rest, so your body's got the best chance to beat the cancer. And then in probably the late 1990s, early 2000s, they started to do some studies of getting people to exercise. And that was kind of where 2010 was kind of the first recommendations that for certain cancers and for certain issues with cancers, the first kind of recommendations for exercise came around. And then that quickly developed to 2017. So COS is the Combined Oncology Society of Australia, I'm pretty sure, came out of this exercise and cancer statement. And the basis at the end is that they all came out, the oncologists, and said every cancer patient needs an exercise prescription. So basically everyone that gets diagnosed with cancer should also be given essentially a script to go on exercise with as well. And even though that's 2017, which is 6 years or so ago, it's still probably not widely implemented enough. And it was also like up until now, we also kind of looked at exercise as mostly like a symptom modifier. So making people feel less fatigued or increasing their muscle mass or trying to look at it as a specific problem. The future of kind of exercise is looking at exercise or treating exercise as an adjunct treatment. So exercise by itself isn't going to kill the cancer and get rid of it, but it has a lot of wonderful effects that go hand in hand with a number of different treatments for certain cancers. And it's got a really, really important role in secondary prevention. So cancer gets primary treated with surgery or radiation, and then trying to prevent recurrence can really come down to diet, exercise, and lifestyle. is what some of the studies are starting to show. So it kind of kick-started in terms of prostate cancer back in 2011. So this study followed nearly 3,000 men for about 4 years. So they found men who walked more than 90 minutes at a normal to brisk pace had a 46% chance of dying of anything. So heart disease, stroke, diabetes, etc., etc. And then they found that men with greater than 3 hours of vigorous activity had a 49%. So you look at those two and it doesn't seem like much greater, more reward to do an extra 90 minutes at a harder intensity. But in terms of prostate cancer specific mortality, so dying from prostate cancer, so the men that did more than 3 hours of vigorous activity had a 61% chance lower of prostate cancer associated death than men with less than 1 hour. And then, not too surprisingly, the men who were doing this before they were diagnosed had the lowest risk. So the quicker and earlier and sooner people are either maintaining exercise as they get older or getting back into it as they get older, definitely the better.
And so vigorous activity equals the 2 to 3, 6, like the
4 to 6.
Yeah,
probably 6, 7 in terms of the RPE. So
yeah, where does it fit there?
So the RPE, so vigorous activity, it's difficult to say because they kind of do it a little bit differently, but we're probably around at least a 6. So in that moderate to just the higher end of moderate, essentially. Yeah. Similar time, so this is 2013. So this study, probably hard to read, but what they did here was they took about 10 healthy 20-year-old uni students and they put them on an exercise bike, and the session got harder and harder. And then at the end, they took a sample of their blood and they spun it in a centrifuge, separates the blood into components, and they took the clear part of the blood, which is where all the good stuff lives, and they took it into a lab, got a petri dish of prostate cancer cells, and they laid this clear stuff over it. And they got about a 31% reduction in prostate cancer growth, which was pretty kind of like everyone kind of went, oh, okay, what's going on here? There's something going on here. So then it took a little while, but they went and redid this study over in WA. WA, Edith Cowan University, we're very, very fortunate in this country. They produce easily the best in the world studies and information on exercising cancer, and specifically exercising prostate cancer. They've done some fantastic stuff over there and still do. So about 2 years ago, they took 10 men who were on ADT, and they did 12 weeks of supervised exercise, including resistance and aerobic training. And so after the end of the 12 weeks, the men lost body fat. So they lost body fat, and they increased their muscle mass and got stronger. But they decided to kind of redo this study. So at their last session, they took a sample of their blood, spun it in the centrifuge, and again, they got a significant reduction. They got a good reduction in the prostate cancer growth in the lab. So that was the first time that goes that even men who have prostate cancer still get a beneficial effect from exercise in terms of trying to reduce cancer growth. So once again, it's in a petri dish in a lab, and going and exercising 23 hours a day isn't going to cure it, but it is having a decent effect. And that's that clinical oncology statement. So no matter the stage, exercise plays a vital role. And so I keep meaning to go back and adjusting this slide because kind of pre-diagnosis, once again, exercise is being shown to reduce prostate cancer risk factors. Same with a lot of other cancers, breast, bowel, lung cancers. And so men on active surveillance, We can kind of have a potential slowing of the cancer growth through exercise, and improves condition for whatever may be on the track down the road. Prostate, reducing body weight makes the surgery easier for the urologist to see what they're doing, and typically improves post-op outcomes. Afterwards, it helps recover quicker. ADT, it helps reduce the fatigue, decrease the fat mass, and maintain bone density and strength. Radiation treatment, so exercise will help reduce the treatment-related fatigue. It can sound a bit strange and a bit mean to say, sorry, you're feeling a bit fatigued, but exercise will actually make it feel better, and can be the last thing someone wants to do, but still trying to maintain some exercise, which will look very different. So all that drumming that you're doing now, Neville, you may still be able to drum with the fatigue, but maybe not for as long. And so it's good to still drum, but you might find that you just can't do it for as long for a period of time if the fatigue sets in. And then advanced disease is another interesting one. So over in WA again, they did a study a few years ago where they had men who had hormone resistance metastatic cancer. So they had prostate cancer that no longer was really responding to treatment, and had kind of had cancer growing in the bones. And they took these men, a group of these men, and they exercised them fairly hard for actually quite a number of years. They kind of extended the study a few times because these men were outliving their initial prognosis. So they were living longer than they were kind of expected to. They maintained really high quality of life, and no one broke a bone. So they had cancer in their bones, hips, and up towards the shoulder. And they were still able to exercise safely in a supervised environment and not break anything, which was pretty amazing. So what does it actually do? There's a lot on this slide. So this is just to kind of help show what it can do around and globally throughout the body. So top right here, so exercise can kind of inhibit cancer cell proliferation through kind of mitigating a whole range of factors, which kind of reduces metastasis and proliferation risks. It can regulate cancer metabolism. So cancer metabolism relies on a lot of different things. And so exercise can kind of increase the perfusion into it. So that was kind of that was one of the kind of things that initially why exercise was kind of, it was like, don't exercise if you've got cancer, because when we exercise regularly and enough, our body can actually start to grow new blood vessels to kind of get more blood to the muscles. We grow more muscle cells, but yeah, we can actually grow our own kind of blood vessels into areas where we're working hard. And so for a while there, it was kind of thought, don't exercise because you could increase more blood vessels, and therefore the cancer could spread more, which initially kind of makes sense, but the studies have kind of shown it has the opposite effect. And when we exercise, we get more blood vessels, but it also helps to get more treatment delivered to the tissues. So people will tolerate chemotherapy better, and potentially have better effects because more of the drug is being delivered into the tumor itself. It also helps kind of regulate the immune environment. So when our muscles, when they contract, they release this really awesome stuff called myokines, and then they go and cause a cascading effect, which releases like natural T killer cells and a whole range of cells which go through and mop up things in our immune system. And we can kind of see that, and you might see that in your own friends and family groups, in that people that exercise regularly almost seem to never get sick. So they're less likely to get the flu or the cold and sniffles that other people may get. And it's because their immune system functions quite well because of all the muscles producing all the good stuff. Exercise has again been shown to reduce cancer risk in a number of things. It enhances the curative effects of cancer treatment. So that's what I was just talking about before, about angiogenesis as this growing of new blood vessels. So we get more blood, more blood vessels and more blood going into and around the cancer, which allows better treatment delivery as well. And reduces the cancer treatment-related effects. So reduces the oxidative stress, which leads to less fatigue, helps keeps the muscle strong, decreases cognitive issues as well. So it does a lot, in essence, and a lot of good stuff, which is awesome. This study this image kind of similar things. So we get improved muscle, improved immune function. These myokines really do awesome stuff. They're only released by the muscles. So the only way we can get more myokine release is to make our muscles work and to hopefully grow more muscle. The more muscle we grow, the more myokines we can release, which is awesome. It helps kind of modulate how things accept. So testosterone into muscle cells, reduces our systemic inflammation, which kind of it promotes and gives cancer a bit more things to use as well. And then changes this tumor vascularization. So kind of cleans it up to allow better perfusion of drugs and medication in to kill the cancer.
Can I ask you a question there? This is
totally
not related to cancer treatment, but reduce systemic inflammation and oxidative stress. Irritable bowel is a systemic inflammation, isn't it? So, So exercise would be good to help that side of things.
Yeah. So I can't give you any specific papers, but yes. So any of those chronic-y kind of systemic inflammation-y type things, most studies will show that exercise has a positive effect. How big that effect depends on a number of different things. But yes, it does help to reduce that oxidative stress just by regularly exercising. Yeah. It's a good question. I like those questions. Again, another paper I don't expect you to read, but this one basically was, so a lot of the studies, again, looking at those myokines coming out of the muscle cells and cytokines. Most of them are done on fit, healthy people without cancer. And so this study, similar thing, they took men who had metastatic prostate cancer and got them to do some exercise, and then sampled their blood to see if they were also producing these myokines, and they were, which is awesome, because it's showing that no matter what stage we're at, our body can still produce things that have a helpful effect in helping us kind of continue to do things that we enjoy. Brief little side note in terms of, so one of the other effects can be like cognitive decline, and a lot of men can go through depressive bouts, being diagnosed with prostate cancer or dealing with treatment after effects. And this study, which was done down, I want to say Adelaide, but it could have been Melbourne. It's done in Australia anyway, but it basically went on to show that regular kind of aerobic exercise of a kind of moderate intensity, again, where the magic seems to happen, about 2 to 2.5 times more effective than antidepressive medication. So really, again, if people are struggling with symptoms or the diagnosis, the best thing we can do is try and encourage them to get out and get exercising. Yeah. So what should you be doing? As close to this as you can get. So about 150 minutes of that moderate cardio exercise, walking, rowing, bike riding. And ideally, particularly for you two, if looking at already on ADT and looking at ADT and radiation, definitely trying to get some strength training into the week would definitely be the key. Once we show that something's helpful, the next thing as humans we want to do is know what the minimal we can do to get the same effects. It's just human nature. Any increase in aerobic exercise provides benefits. lower amounts of resistance training, if done at that moderate level, can be just as effective as numerous sessions. So doing one good session, reasonable amount of load, doing major muscle groups. So just think like something upper body that's pushing, something that's pulling, something that's pushing up, something that's pulling down, and then same with the legs. So, it doesn't need to be any more than really 6 to 8 exercises, and then you're on the money. So the main summary is that exercise is a vital synergist. So we shouldn't be thinking of exercise as an optional extra when it comes to prostate cancer. It should be vitally, everyone should be encouraged and promoted and needs to do it. Something's always better than nothing. Our national guidelines are quite helpful in terms of diet and exercise and helps improve the outcomes. And if we're not sure where to start, just ask. So GPs can usually find an exercise physiologist in the local area. The enhanced primary care plan, like the Medicare care plan, can be used with physios or exercise physiologists to help get you started. There's a lot of helpful stuff out there as well on the PCFA website as well. Yeah.
And the other thing, which I don't know whether you're familiar with this, but when they start their ADT, most of the pharmacology have a exercise program linked to the ADT.
Yeah, correct.
Exercising.
Yeah. But I'm just linking in with somebody that's actually able to give you that prescription. Anybody that has an injection for ADT automatically gets the opportunity to link in with an exercise physiologist.
Like the WellCare plan or something like that. Just basically.
And they'll do the 12-week program this year.
Yeah, correct.
Because we're in a regional setting, predominantly what seems to happen is that they'll do a face-to-face with several participants over a Zoom session, which seems to be the most effective rather than going to a clinic or a practice.
Yeah.
Certainly, I'm really grateful for AbbVie and another one that they all promote exercise as being the number one thing to help with ADT.
Yeah, I think Mundy Farmer.
That's it.
Yeah. They had the man plan a little while ago. I'm not sure if they still do the man plan, but they still continue to have funding for hormone therapy, and everyone, if offered the opportunity, should definitely take it up. Because it's particularly ADT, like it's I find a lot of men get counseled and educated on the you might have hot flushes, you might have mood swings, you might notice a reduction in your libido, maybe some tenderness at the breast, but it's not, they don't always get you're going to put on fat mass, you're going to lose muscle strength and density, and you're going to lose bone density. Like those three seem to not get talked about as much because they're not immediately felt, but they're typically the far more detrimental ones in the long term.